Welcome to an hour of HealthMade Radio. HealthMade is a community for natural health seekers where we educate people about common health conditions and share extensive research on the most effective natural health treatments and promote legislation that protects our health freedoms. A core concept belief is in the innate intelligence and healing power of the body, and if properly supported spiritually, emotionally, and nutritionally, it can find its way back to health. HealthMade Radio will bring information from integrative health experts throughout the world. Health is what you make it. I'm Dr. Michael Karlfeldt, and I will be your host. Today's guest is Dr. Halasa. Dr. Halasa earned his medical degree at Tripoli University in Tripoli, Libya in 1998. Dr. Halasa was a researcher in immunotherapy at Baylor University in Texas, clinical associate at Compassionate Pain Management in Delaware, and has published nitromedicine articles with Dr. Hamblin at Wellman Center for Photomedicine in Massachusetts. Now he's the founder of Chronic Disease Prevention and Management Centers and Nonprofit Academy of Oxidative Disorders. Dr. Halasa is a frequent guest speaker at renowned venues such as International Society for Optical Engineering, American Society for Laser Medicine and Surgery, Nitric Oxide Society, American Academy of Anti-Aging Medicine, ISLA, Florida Academy of Pain Medicine, Photobiology Society, Boston BioLife Conference, and American Academy of Stem Cell Physicians, American Osteopathic Society and Rheumatic Diseases, and Academy of Oxidative Stress Disorders. Dr. Halasa, it's such a pleasure to have you on the show today. I know that you are at the forefront of some exciting technologies and exciting therapies to really assist and help people that are dealing with chronic diseases, and we're going to get more into detail as to what those are. So thank you so much, Dr. Halasa, for being on the show today.
Thank you for having me. So
Dr. Halasa, you are kind of pushing the envelopes and some of the areas that regards to health and healing, and obviously one of the things that we're dealing with that's becoming more and more of a plague are these chronic diseases, and obviously cancer is one of them. They have all these autoimmune conditions and chronic infections and so forth. So tell me a little bit about what does your research entail, and why you're excited to go in that direction.
Yeah, I think we have a big gap in managing chronic disease, and I'm trying to fill it. When I was doing pain management, I can see all those pain management drugs that we are giving is actually causing more harm with time, especially giving it chronically. I mean, I can see the narcotic will benefit patients in acute conditions, but chronically, it seems like they're getting worse, and they're getting addicted, and even their pain is getting worse. The central pain is getting worse with time, and so at that point, I thought we need to really change the way that we manage pain, which include the chronic diseases that underlying those pain conditions. And so I start working with Dr. Hamblin from Harvard Medical School and doing research with him, seeing how photomedicine may help in restoring the redox balance and the homeostasis of the body. And we have great results doing photomedicine to manage pain conditions. And then I worked with Dr. Weber from Germany using light therapy to manage cancer, what we call photodynamic therapy, which is basically injecting photosensitizing the body, which will concentrate in the cancer, and then you shine light, and that helps to generate free radicals that induce apoptosis to kill the cancer. So it has minimum side effects than giving chemotherapy and radiotherapy, and we help a lot of patients to improve their quality of life. And then we end up trying to find out how we can deliver the drugs into the pathology without going to the healthy tissue. Like, we know that the problem with cytotoxic drugs is that when you inject it to the body, it causes side effects because it's affecting your healthy tissues, and in addition to damaging the cancer tissue. we need that damaging in the cancer tissue, but we don't need that damage in the healthy tissue. So we start looking at how we can see the difference between the behavior of healthy tissue and the normal tissue, and we find out that the blood vessels of the healthy tissue are more strict, while the pathological tissue, they are very leaky to nano-sized particles. Knowing that, we can now load the drugs and wrap them inside nanoparticles, vesicles made from phospholipid or PLGA, that you can do it through the manufacturer. Or we can take the patient's platelets and break it down into vesicles and mix them with those cytotoxic drugs and wrap them around the platelet-derived exosomes or vesicles and inject them to the body, which will take the drug into the pathology, into the cancer, for example, without affecting the healthy tissue. And that minimizes side effects, increasing the efficacy of the drug. And I think this is the future of medicine, which is nanomedicine. I think all the big pharma and nutraceutical are wrapping their ingredients and their drugs and supplements into nano. So I'm trying to take all those resources and all those tools and help the doctors in building a very great arsenal that we can manage and help to fight cancer and other chronic diseases using those innovative technology.
I mean, this is pretty revolutionary. I know that this is something that we are bringing to our center as well here at the Karlfeldt Center. We're working hand in hand with you to bring this to the general public. But I mean, this sounds really revolutionary to be able to then have this kind of targeted approach where you can then, whatever agent it is that you are wanting to get into the tumor cell, you're able to use this type of technology or this methodology to make sure that it has a higher concentration in the tumor cells versus in healthy tissue.
Right, and it's not just cancer. Any pathology out there, whether it's inflammation, autoimmune, degenerative, they tend to be leaky to nanoparticles. So you can manage all kind of chronic disease, including cancer, infectious area lesions. So yeah, I believe this is the future of medicine, nanomedicine, and most of the big pharma are moving to that direction. Most of cancer drugs are moving that direction. It takes many years for them to go through all those clinical trials and all that, and I think we can speed the whole process just using generics that's already been approved by FDA and wrap them inside, in the clinics using platelet-derived exosomes, which is from the own body, those platelets. So you are loading the drugs from the platelets that's being extracted from the patients. And so it's very, it's autologous, it's something from your body, so there's no really any side effects doing your own, using your own components of your body to deliver drugs into the pathology.
So going back, you were talking about pathological tissue and how that kind of responds, or that kind of inflammation makes the blood vessels leaky, and that way it allows then these different particles and to accumulate within that tissue because the blood vessels are leaky, and then these little substances then can leak out of the blood vessels in that tissue more easily. But are there other, with the technology that you are bringing forth, I mean, is there another way, that inflammation, is there another way that the particles that we are infusing, that they're being driven to that inflammatory place?
Well, there's few soft drugs out there that they have a tendency by itself, even without wrapping them, they tend to attract to the pathology. An example is methylene blue, which I use it as a photosensitizer to manage many chronic diseases. It's very effective in buffering the redox and also helping cancer because they act like photosensitizers and also infection. So they have a tendency naturally, those chemicals. You don't need a nano, but doing nano is better. to concentrate into the cancer and infection area. But the other thing we have is platelet-derived exosomes. Exosomes of the platelet themselves, they have natural receptor that tend to attach and attract to pathologic cells. They have receptors that naturally attract to cancer cells, bacteria, senescent cells. It's naturally they tend to attract to those pathological cells, and that's a good thing because that's what we're taking advantage over that, and take those exosome loading with drugs so they can carry them to those targets. In order to do it synthetically, through the big pharma, and you need to develop antibodies and putting on the surface of those nanophysicals in order to further target those pathological cells. But we can save a lot of money and use your own natural receptors at the exosomes that will further deliver the drugs and the supplements into the pathological cells. So that will add more targeting effect and efficacy of the drug when you have, two things. One, because of the leakage, and the second, because of the receptors on the surface of those vesicles that has tendency to attract to the cancer cells or infected cells or senescent cells or inflamed cells.
Yeah, so that seems to be much more elegant in my mind, because you have these pharmaceutical agents. We obviously we develop them and put them together chemically, but if you look at the evolution of your own body and the intelligence of your own body to be able to then use what already exists there and that has evolved and it's functioning perfectly fine, like you were talking about these extracellular vesicles or exosomes is another term that you used, and that they are naturally drawn to inflammation. So now you have a way to then guide these agents, these kind of, if you use nutritional agents or you're talking about methylene blue or whatever it is, you want to load these exosomes, and you can load them, and then they get shuttled to then the location of the pathology, or where you have inflammation, or where you would have cancer, or where whatever there's tissue that there's inflammation. Obviously, cancer is a very inflammatory condition, and then it can go there, and then it sticks there. So then you have a transport mechanism, and then you have an ability to kind of have it stick there, so it stays there. And because of like you said, when the blood vessels are leaky, then they are more easily able to enter into the tissue from the blood vessels in that area of inflammation. And isn't it true also that the circulation in that area, the blood flow is slower, which gives it more time then to kind of accumulate in that tissue?
Yes, there's many factors, and this is one of them. Of course, when you have slow blood, it gives a chance for those nanoparticles to seep into those inflamed tissues, those leaky blood vessels. The other thing is, if you compare between platelet-derived exosomes as a carrier versus the nanoparticles of the manufacturer, which is made from PSGA and phospholipids, we have more advantage in autologous platelet-derived exosomes over the nanoparticles made by the big pharma. And the reason why, because if we have a cancer in the brain, and we inject those doxil, which is doxorubicin loaded inside phospholipids made by the manufacturer big pharma, they will go to the brain, yes, but there's a percentage of it will be trapped by the macrophages of the livers, and so we're not getting the whole nanoparticles into the pathology, the brain tumor. And why? Because the macrophage, they start screening them and picking them up and cleaning them from the blood because they consider those synthetic nanoparticles as a foreign. Versus if we use platelet-derived exosomes from the same patient or even from other patients, because the platelets are autologous for everybody. In other words, I can use your platelet, you can use my platelets without being recognized as foreign. That's why we have blood transfusion and platelet transfusions, and it's very effective in managing cases when platelet is low. So they are less immunogenic. And so, but of course, I prefer the platelets from the own patients over the other person, just to make sure, completely it's autologous. There's no and immunogenicity there. And so when we inject those platelet-derived exosomes carrying the drugs, they will not be trapped into the livers or be cleared, because the liver macrophage will see them as self-antigens and self-body and self-exosomes. So it's act like a torsion. And so you get more concentration of those cancer drugs into cancer using your platelet-derived exosomes over loaded with doxorubicins over the big pharma, which is the doxil, which is doxorubicin loaded inside synthetic nanoparticle. So that's the beauty of doing the nanomedicine in the clinic and loading the drugs inside the platelet-derived exosomes. I think it's more effective than the synthetic ones, and there is a study for that, clinical trials, and they made a study in comparison, and they proved this is true.
Great. Well, I'm going to take a quick break. You're listening to HealthMade Radio. I'm Dr. Michael Karlfeldt. I'm here with Dr. Halasa. We'll be right back. Welcome back to HealthMade Radio. I'm Dr. Michael Karlfeldt. I'm here with Dr. Halasa. We are discussing the frontier of medicine using nanomedicine, photodynamic therapy, photoregenerative therapy, nitro redox therapy. So it's very, very exciting to be kind of discussing what the forefront of medicine, what it's looking like, and how it can be utilized for patients dealing with severe chronic diseases. So you're talking about, doxorubicin, which is a chemotherapeutic drug, and obviously one of the biggest issue when you do chemotherapy is, how much enters into the tumor and how much gets, goes into, rest of the tissue, and how much does the liver clear, like you were talking about the macrophages, within the liver, from the Kupffer cells, how they clear this medication, even if we're then packaging it in a liposomal kind of delivery system, which they use now to increase the concentration of the drug within the cancer cells. So even with that, you still have that clearance or that kind of destruction of it within the liver. So I'm curious percentage-wise. How much of the medication? Let's use doxorubicin, the chemotherapeutic drug, as an example. How much of that tends to end up in the actual cancer when you infuse it?
So you're talking about the naked doxorubicin without any nanoparticle, right?
With any altercation, yeah. So let's say somebody would just go and get chemotherapy intravenously. How much of that tends to end up in the cancer cells, percentage-wise?
Less than 10% goes to the cancer, because this drug will diffuse all over the body. So you get less than 10% going to that cancer cells.
Yeah, which is pretty abysmal. And I'm heard even kind of percentage-wise, that's even less than 1%. Like in some ways, it's like 0.001%. Yeah, so it's a very, very
we're talking roughly. So
yeah,
roughly you get that number, and maybe less Yes.
Yeah, so it's, I mean,
which is very not good. That's mean most of the drugs is just harming your healthy tissue, causing hair loss and liver damage and all the side effects that you see with chemotherapy. So wrapping it inside the nano would definitely help to go up more than 50% goes to the cancer with wrapping it to the nanovesicle. And that's a big difference of percentage. And if you said you have studies less than 0.0%, I think nanoing it will definitely add a lot of advantage of minimizing the side effects that we experience with naked chemotherapy.
And like you're saying, if you're wrapping it in a vehicle, we're talking about this platelet-derived nanoparticles, from the patient, their own platelets. Obviously, like you're saying, the immune system is not going to go after it. The liver is not going to go after it. It's going to be looked upon as a normal part of the tissue, and then that is going to then be driven directly to where the inflammation is, which means now it's going to the diseased area, not messing with the healthy tissue. Your response is going to be so much better, and obviously the toxicity is going to be tremendously less.
Right. Yes.
So,
I agree.
So what are some things? I mean, obviously we are not there yet where people kind of you go to a clinic and they're using chemotherapeutic drugs, and you're able to kind of wrap it in these exosomes or platelet-derived nanoparticles. We're not quite there yet, but we are currently able to obviously use a number of other nutraceutical agents, and you were talking about like methylene blue, and what are some other things that can be utilized in regard to something like cancer?
Well, any drugs and supplements that's injectable, that's FDA approved, you can wrap them inside the platelet-derived exosomes, just mixing it, and with certain technique at the clinic, there's minimal manipulation, and you can get better results out of it. And there's publications and research already being done, and it works very good and very effective, way more effective than even the nanovesicle that's being made by the manufacturer, because we are able to overcome the challenge of the liver macrophage clearing those synthetic macrophages, clearing those synthetic nanovesicles made from phospholipid and PLGA. So yes, I think we can use all injectables out there, including methylene blue, ICG, indocyanine green as a photosensitizer. We can use supplement like N-acetylcysteine, vitamin B12. So we can load any injectable drugs, even steroid, even the cancer drugs out there. We can load them into those platelet-derived exosomes and inject them to the body. I mean, I don't, as long as the ingredients and the things that you are using, it's within the norm and acceptance of the regulatories, I think it's okay. As long as you sign a consent with the patients and say we are mixing drugs together and giving it to you as a mix, we think it has more synergistic effect than just injecting a naked chemotherapy. And I think it will be more effective in managing those conditions.
Yeah, I agree. We're going to take another quick break. You're listening to HealthMade Radio. I'm Dr. Michael Karlfeldt. I'm here with Dr. Halasa. We'll be right back. Welcome back to HealthMade Radio. I'm Dr. Michael Karlfeldt. I'm here with Dr. Halasa. We're discussing nanomedicine and how that can be used nutraceutically also photodynamic, photoregenerative therapy. So let's say, for instance, I mean, you have the substance like NAD, which is kind of a vitamin B-like substance, from vitamin B3, that has been used intravenously. You can also do it orally to really turn on the metabolism, turn on energy. People just, for chronic fatigue, it's really fantastic in those areas. So what would be the difference if we would kind of load that type, or like vitamin B12, into these nanomedicine versus just doing it directly intravenously or taking it orally? What would be the difference?
It's all about what you're looking for that drugs to do. If you're looking for that drug or supplements to affect only the pathology and not to go to the healthy tissue, then nano is the answer. But if you want that drug to go everywhere to benefit all the tissues, whether it's healthy and non, then just give it naked. So, it's all about the purpose of the treatment here. So if the NAD that you want to be only for pathological tissue to be used and not the healthy tissue, then wrap them will be an answer. But if you want to have NAD to be both for the healthy and the pathology, then just inject it as it is. You don't need to wrap. So it's all about the purpose of giving those drugs.
So let's say that you are dealing with a tissue that's not regenerating very well. Let's say you have a autoimmune condition, and it's inflammatory, and the tissue is not repairing very well. So, and that can be any kind of autoimmune, whether you're dealing with Hashimoto's, get inflammation there, pancreas, something with the pancreas, or ligament, joints, whatever it may be. So if you, let's say that you would do something like NAD, that turns on the energy production, and you put that within that delivery system, with the nanoparticle, you would then be able to have that drive to that diseased area, where you have the inflammation, and then turn on the energy within that area to speed up tissue repair. Am I correct with that?
Yes. So I think that's what you're targeting, the pathology. You're trying to concentrate your drug into the pathology more than the healthy tissue. So I think it's better to nano those drugs and inject it as nano. And you can get better results because if you inject it as naked, it goes everywhere. So you get little small percentage going to the pathology, where it goes to other tissue where you don't need it. You're more focused on healing that lesion, that pathology. And I think nano is the right way to do.
So it almost seems to me that even though you may not be dealing with something chronic, because most of us are dealing with inflammation at some level, and if we want to do preventative medicine or regenerative medicine, to be able to utilize this technology, you will then target your weak areas to heal those weak areas, and that will then prevent disease later on. I mean, wouldn't that be of benefit?
Yeah, if you're targeting any inflamed area, then nano is the answer, because inflamed area, whether it's coming from cancer or infection or autoimmune or degenerative, they tend to attract and accumulate those nano more, and I think you can increase the efficacy of the treatment doing that, yes.
And you were talking a little bit also in the introduction, you were talking that you were working with Dr. Michael Hamblin, and he's a leader in light medicine, I would say, any kind of photodynamic therapy or photoregenerative, photobiomodulation, whatever term that's being thrown out there. And you're also mentioning things like different photosensitizers, like methylene blue. You were talking about ICG. So you can then use these photosensitizers and then pack them also within this kind of package these nanoparticles, and then they will accumulate into tissue, and then you can use, and that will then pull light to that tissue, right? And then you will then have more of an impact within that tissue of that light.
Right. So basically, we try very hard to use only FDA-approved ingredients when we are using photosensitizers in photodynamic therapy. And photodynamic therapy is well recognized in the mainstream medicine as a valid treatment to manage cancer and infection. And there's many FDA-approved applications for photodynamic therapy currently. And yes, I did work with Dr. Hamblin. I published articles with him, 2 articles, one in 2014 and one in 2016. The 14 one was combining nitric oxide, platelets, stem cells, antioxidants to manage chronic disease. The second one was nitromedicine as a new field of medicine to manage chronic disease by modulating the nitrodox sensitive epigenetics and biochemical pathways. And we work together, and I think the terminology of photomedicine is being changed into photobiomodulation by Dr. Dr. Arvin, I think, and he works in Buffalo University, and I think now I'm trying to rename photobiomodulation into photoredox modulation because the mechanism of light works through modulation of redox. So that specifically shows the mechanism of action of the light. It's modulation of redox and buffering the redox by affecting the mitochondria and exciting those electrons and or by releasing the nitric oxide from the mitochondria. So that's the mechanism of action. But yes, I think using photosensitizer that's FDA approved or supplements that is recognized by the regulatories, you can use all that. You can even use cancer drugs because there is a lot of publication out there using low-dose cancer drugs and load them inside nanoparticle, use low-dose chemotherapy versus high-dose, and activate them with light. There's a lot of publications and, is moving the cancer treatment to that direction. And also, there is a new field of medicine called personalized medicine where, the old school giving this cocktail of cancer drugs, it's going to help this type of cancer and all the cancer of all different patients, regardless. So you can use this cocktail of cancer for ovarian cancer, regardless of the patients. So all the patients, they will use this cocktail, solid cocktail. That's a big pharma. Things that changed recently because we find out the ingredients of those cocktail of drugs are regimen. Some patients are sensitive to it, some patients are not, and that's where you have a new field of medicine and lab that detect the sensitivity of the cancer to those drugs and tells you, well, this patient is sensitive to doxorubicin, but this patient is not sensitive to doxorubicin. So it's not wise for you to give doxorubicin for that patient who's not sensitive to it. And so this is called personalized oncology, which is a way ahead of the classic oncology, where now we can tell the patients, this is the drugs that you are sensitive. This is the new regimen that we're going to give it to you. We're not using the old regimen because you are insensitive to the ingredients of this classic regimen. And I think this is more effective because if you give a patient and they are resistant to that certain cancer drug, the reality is that you're causing more harm than benefit because you will be destroying his immune system, and the cancer is insensitive to it, so this may lead to progression of the cancer. But if we can screen them and know exactly which ingredients is effective, which not, I think we can create a cocktail that is more powerful, more effective for that certain person. And that has to do with genetic differences between individuals. And we need to consider that and put in equations when we are treating patients with cancer. It's the same concept before when we are treating bacteria. We are doing antibiotic sensitivity to make sure that we don't give antibiotic that the bacteria is insensitive to. Because that will be kind of waste, and we'll be ending up developing resistance by just giving antibiotics randomly. So drug sensitivity for antibiotics, it's very important. The same concept applies to the cancer, and cancer drug sensitivity also is very important, and screening those drugs that's sensitive to the patients. It's very critical, and that helps to advance oncology, and we still behind the curve up to now. I don't see much of oncologists are moving to that direction. So only few who are the frontier are using that. But I think cancer treatment is going to change in the future, and we're going to be more personalized and moving to that direction of personalized it, and also moving to the direction of nanomedicine.
Yeah, that's some exciting changes that we're looking forward, and I'm glad that you are part in that process to drive that forward. We're going to take a quick break. You're listening to Health Made Radio. I'm here with Dr. Halasa. We'll be right back. Welcome back to Health Made Radio. I'm Dr. Michael Karlfeldt. I'm here with Dr. Halasa, and we are discussing nanomedicine, photodynamic therapy, nitro redox therapy. So we're talking a little bit about the photodynamic therapy. So with that, we're using photosensitizers, and then you were talking about methylene blue and ICG, which obviously are FDA-approved drugs. And you mentioned how important that is, to stay within the normal regulatory what is approved, and then you infuse that, and that then accumulates. So if you then use these extracellular vesicles or kind of like an exosome-like substances that are then drawn to the inflammatory place, which is where the disease is. Again, cancer is an inflammatory condition, and they stick there, meaning the blood vessels of the cancer is leaky, so then they kind of accumulate in the cancer more easily, and so now you have all these photosensitizers, and then you shine a light on that. You get light into that area. What happens within the cancer cell when you have a photosensitizer within the cell, and then light is being shined on that? What happens, and what kind of light do you need? I mean, can any light do, or what do you need to do?
No, you have to have a specific light within the absorption range of that specific drug. So every drug, every substance in this universe, they have certain spectrum of light that they can absorb and excites their electrons. And there's more drug that's more excitable with light than others. And the one that's more excitable, that their electrons get excited with certain bands of wavelengths of light. Those are when we call them photosensitizers. And most of cancer drugs, they are photosensitive. They can absorb light, especially below the ultraviolet light, and they get excited, the electrons, and those electrons, they will be picked up by the oxygen and become free radicals, and those free radicals will induce apoptosis and kill the cancer. So the mechanism of action here is the generation of free radicals that will induce apoptosis by exciting the electrons of the photosensitizers using light. So adding oxygen therapy or ozone therapy with photodynamic, I think there's a synergy there, because you're adding the oxygen and you're exciting the electrons to stimulate the reaction of oxygen with the electrons and generating free radicals that will induce apoptosis to the cancer cells and the bacteria cells or the senescent cells or inflamed cells, inflammasomes. And that's why we can manage all those chronic diseases by just using photodynamic therapy.
So that, I mean, it seems very, I used the word elegant before, because you're able to really target the tissue, and then if I'm hearing you right, then you're creating a huge oxidative stress, or these kind of free radical components within the cancer cell, and then, the cancer cells die. And this, since it's accumulating then more preferably in the cancer cells, then this should be very effective and also non-toxic by doing it this way.
Yeah, it's more targeting because the cancer cells are the one who accumulate more of those photosensitizers, whether because of its nano-delivered or in the case of metal and blue, even without nano, they tend to concentrate more in the cancer than healthy cells. So yes, you got the targeting effect there. But you have to understand that even other way of killing cancer, most of those drugs that we use in chemotherapy, they work the same way. They interfere with the metabolism of redox of the cell, of the cancer cells, and they increase the free radicals, and the free radicals induces apoptosis or oxidation, damaging the cancer. So chemotherapy works the same way. Radiotherapy works the same way. Those light from the radiotherapy, they electromagnetic waves from those radiotherapy, they induce damage through oxidation, through increasing the free radicals. So that's how we destroy things. It's by oxidations. And so we have the common mechanism, whether it's chemo, radio, photo, they all work through oxidation, and that lead to inducing of apoptosis or necrosis if it's very high, those free radicals.
And the only difference here, from what I'm understanding, is that if you do chemotherapy, it splatters a little bit all over if you just do it that way. But if you use this type of technique with nanomedicine or photosensitizers, you are then more likely to just hit the targeted area rather than impact healthy tissue.
Right, unless the chemotherapy is being used as a small dose and nano it, then you are increasing the targeting therapy for that chemotherapy. And that's what the whole goal here is, to lower the dose of the chemotherapy and nano it, so you can get more of targeting the cancer cells and less damaging of the healthy tissue. Yes, I think this is the best way of managing cancer is just trying to get rid from the pathology without damaging the healthy tissue.
Well, it's very exciting technology and methodology that you're bringing forth to help people with chronic diseases. I know we've talked a lot about cancer as an example, but like you mentioned, this translates over to any kind of inflammatory condition, which obviously all degenerative, all autoimmune, all of these are inflammatory conditions. So this type of medicine is usable in all those areas, because you're able to target these areas with these platelet-derived nanoparticles that comes from the patient themselves, which means that the individual is already carrying their own medicine. You just kind of pull it out of them, and you concentrate the platelets, and you use different methods to be able to load these agents into them, and then also kind of do it in such a way so that they become nanonized, and then get them into the location and infuse that intravenously, and then it becomes it can work in all those different diseases.
Right, but let me make sure for the audience here to understand that cancer is not easy to get rid from it, because they tend to resist all the drugs that we're giving, and they change their behavior, and they can influence even the surrounding immune system and make the immune system defending them instead of attacking them. So that's you need to understand that cancer is not easy to get rid. You need to in order to really manage cancer, you need to understand the whole mechanism of resistance of the cancer to those drugs. And one of the ways that they resist, they become, we have something called cancer stem cells. And those cancer stem cells, they behave like normal cells. They have the powerful antioxidant capacity that will neutralize those free radicals you're trying to induce through radiotherapy or chemotherapy or photodynamic therapy. And the way that we're trying to get rid from those cancer stem cells is to give patients polyphenols that helps increase sensitivity of the cancer stem cells to the free radicals damage. So we need to work in increasing sensitivity of those cancer stem cells to the free radicals because they have very powerful antioxidant capacity as equivalent to the normal cells. The other thing is that some cancer cells, they start secreting interleukin-10, which will suppress the immune system. And to the point they can modulate the Th1, which is the cytotoxic T cells, and Th1 helper cells into Tregs, which are the one that actually cause suppression to the immune system. And so they can make a layer of your immune system defending them instead of attacking them. So you need to work on how you can change those XTH1 Tregs back to Th1. So there's a lot of work needs to be done when we are managing the cancer. We need to look at it from the immune therapy aspect and how you can modulate the immune system to make sure that you're empowering the effector T cells, which is the Th1 mainly, to destroy the cancer cells and preventing that kind of tolerance that the cancer can induce by secreting cytokines that will suppress the immune system. So you need to work on that layer. You also need to work on the layer of the cancer are inducing fibrosis, and they can wrap themselves inside the fibrotic tissue and become resistant to the cancer drugs. So you need to give patients antifibrotic drugs. There's many things. Also, they can wrap themselves with platelets. Platelets give them the cover. So you need to work and maybe possibly giving patients with antiplatelets. There is a lot of things that needs to be done in order to counteract all the resistance that the cancer can lead. And I think of understanding cancer behavior and cancer resistance, we can better understand how to manage cancer. So it's not one way. You have to look at from different angles and understand the cancer resistance and cancer tolerance and all the mechanism behind it and how to tackle it and empower the immune system against the cancer and target your drugs and therapies against that cancer cells without, causing damage to the healthy tissue.
Yeah, obviously there's a lot to do before we're able to solve the riddle of cancer. It's not just a one size fits all. Like you're talking about, it's personalized medicine that we need to go towards. Just one question before we finish. So you're talking about these cancer stem cells and how important it is to control them. What does chemotherapy, if you only would do chemotherapy, what does that do to these cancer stem cells? Because it seems like they play an important role in the whole process.
Most of the time, they are not effective against cancer stem cells because the cancer stem cells is just hard to get rid from them, especially in stage 3 or 4. You cannot really eliminate all those cancer stem cells. I can see if it's stage 1, that's possible, but when it comes out into stage 3 and 4, and you have this number of cancer stem cells, they behave like normal cells, and so those chemotherapy they cannot really get rid from it because those cancer stem cells resist it. They can neutralize them, and so that's the reason we need to think of how we can increase the sensitivity of those cancer stem cells to the chemotherapy, to radiotherapy, to the photodynamic therapy. Using polyphenols is one way, but we need to look at it from all different angles because there are some cells they hibernate too, and they stop dividing when they are experiencing the chemotherapy. And when you stop the chemotherapy, they go back to the proliferation and they start dividing and invade the tissue and spread. So they're very smart. Those cancer stem cells are very smart, and they are able to hibernate and hide from the treatment that we are giving. And they can also change the immune system and make them protecting them instead of attacking them. So we need to learn about the cancer behavior and all the tricks they do, and find a way to overcome those tricks.
And polyphenols, those are things like EGCG and curcumin and boswellia and those type of things, correct?
Yes. I think they're helpful, but we need to dig more and find out more about the cancer behavior and all the tricks, and work on those tricks and try to encode them. Yes.
Wonderful. Well, Dr. Halasa, thank you so much for taking the time, and thank you so much for everything that you do to drive this forward, to bring this out to the consumer to maximize the effect of what we're trying to accomplish, whether it is autoimmune or joint restoration or tissue regeneration or cancer, like you're saying. And it's truly a pleasure to kind of work with you to implement some of these strategies. So thank you so much, Dr. Halasa. I really appreciate you taking the time.
Before we end the sessions, I'd like to, first of all, thank you for giving me this opportunity. And I would like to announce that we are looking for more doctors to join us and become a chronic disease prevention management specialist. And we will provide them with the platform of education that they need to become a follow with us. And I need your help with that too, and to bring more doctors in our webinars that we have, so we can learn from each other and work together as a team, and finding solutions in advanced medicine by discussing all those hard to treat cases in our weekly webinars. So I'd like to extend my hand to the doctors to join us in chronic disease prevention management centers. We are trying to get a pioneer in the States, and also we're trying to train follow doctors to adapt our protocols. And I think doing that, we can advance medicine. We cannot do it by me and you. It has to be a team of doctors, which I am developing, and we have almost 5 states covered. But we're looking for covering all the states, and possibly moving globally. And I start working with some Australian doctors and Canadians and UK doctors, and they're interested to join this network, this mission to advance medicine and fight disease.
Yeah, I agree. Yeah, the more of us that can work together, the faster we'll move this forward. And I thank you so much. It's an honor to be part of that process and to work with you. And it's really exciting to see, what can be done. I mean, it's all very exciting to see what we're doing now, and then obviously there's a lot more to learn. So thank you so much. That is it for today. You're listening to HealthMade Radio. Remember to check us out at healthmade.co. Health is what you make it.